Somebody said this is a great day for me, and this is indeed, at least so far, and we will see the second one, who is actually Zsuzsanna Domokos. And I have to say that here I'm only 50% supervisor, because the other one is Oshaya Németh, actually, who did the first part of the tutorialship, and then I took it over actually 1.5 years ago or so. But by that time, both two papers were submitted, so I did just a very little job, I have to say, on this. I'm still very proud of Zsuzsa too, who actually, if I start there, that she completed her study at the Deák téri Evangelikus Gymnasium, which is actually, I mean, that's the Deák Square Evangelical Church Secondary School, which is one of the best Hungarian secondary schools. So the school was very good, the foundation of this. And then she came to Semmelweis University, and then she completed her MSc in Dentistry. Then she started to work as a resident and also as a PhD student at the Department of Community Dentistry. And then later on she moved actually to a private practice when she worked. So she is a real practitioner dentist. Yeah, I mean, she should have applauded this too. Actually, this is more or less it. And I'm very thankful, actually, to have these two PhD students. One already completed, the other one will complete, hopefully, in about 45 minutes or so. And please welcome, actually, Zsuzsanna Domokos.
Thank you very much for the kind introduction. Dear audience, dear committee members, dear colleagues, I would like to present my PhD thesis, which is Beyond the Limitations of Conventional Periodontal Care, Multidisciplinary Approach and Novel Methods. My name is Zsuzsanna Domokos. I'm a dentist and a PhD student at the Center for Translational Medicine, Semmelweis University. My vision is to develop interdisciplinary knowledge by investigating the association between dental and systemic diseases, and also improve the treatment which involves both dentists and medical doctors. My mission is to incorporate multidisciplinary attitude into clinical practice based on a comprehensive knowledge. My specific goals in order to fulfill my vision and mission is to identify a possible risk population in periodontology through a meta-analysis, and also I would like to improve the diagnostic and the follow-up method of patients with periodontal disease, therefore are evaluated the reliability of a novel biomarker, MMP8. I strongly believe that real research questions arise in clinical practice. However, these questions should be answered through scientific inquiry, therefore we can apply evidence-based medicine. In our meta-analysis, the scientific accuracy was also one of our main focus. Therefore, we also set as a goal to increase the accuracy, therefore the current level of evidence from previous meta-analysis, by overcoming former limitations. Also, we believe that high-quality systemic evaluations are needed to assess the reliability of a novel biomarker before implementing it into clinical practice. The title of our first meta-analysis is Patients with Inflammatory Bowel Disease Have a Higher Chance of Developing Periodontitis. Periodontitis is one of the most common oral conditions in the world. According to different studies, some kind of periodontal disease affects 20 to 50% of the adult population. However, severe periodontal disease affects 10% of the adult population, and it is the major cause for tooth loss. Moreover, periodontitis is not only an oral condition, but it can also contribute to coronary heart disease, preterm birth, stroke. Therefore, it can also cause the death of the patient. It is known that there are several risk factors that can contribute to developing periodontitis. Some of the most known are poor oral hygiene, smoking, but there are also some systemic diseases like diabetes mellitus and hematologic disorders which are associated with this disease. And our question was that if inflammatory bowel diseases are also associated with periodontitis. To thoroughly investigate this issue, we investigated separately if inflammatory bowel disease patients have a higher chance to develop periodontitis, and in the other way around, if patients with periodontitis have a higher chance to develop IBD. As both diseases are multifactorial, investigating this possible association between them could widen our knowledge and also improve the treatment methods of these diseases separately as well. We might find some common environmental or genetic pathways or some immune inflammatory pathways which can be a cause of this association. The aim of our study was to investigate the association between periodontitis and IBD from both directions and identify a possible risk population in dentistry. On this slide, I present how we answered our scientific question, which was if there is a bidirectional association between periodontitis and IBD. To answer both the questions separately, we formulated two PICOs. PICO 1 to answer if IBD patients have a higher chance to develop periodontitis, and the second PICO to answer if patients with periodontitis have a higher chance to develop IBD. On the following slide, you can see the detailed search key which was used, which resulted in more than 1,000 articles. And in the end, after the full text, the title, abstract, and full text selection, we ended up with 14 eligible articles. As a primary outcome, we investigated the prevalence of periodontitis in patients with IBD and IBD-free groups. Therefore, we could calculate odds ratio values. The odds ratio for this evaluation was 2.65, and also these results represent statistical significance. This means that patients with IBD have a higher chance to develop periodontitis. After that, we investigated Crohn's disease and ulcerative colitis, the both forms of IBD, separately as well. In the case of Crohn's disease, the odds ratio was 2.22, and in the case of ulcerative colitis, the odds ratio was 3.52, which means both forms of IBD patients have a higher chance to develop periodontitis. For our second PECO, we found only 2 eligible articles. Therefore, the statistical evaluation and getting reliable results is not possible as yet. However, both studies concluded that periodontitis is a risk factor for subsequent ulcerative colitis. However, this is not true for Crohn's disease. As a conclusion, we could conclude that patients with IBD have a higher chance for developing periodontitis, which holds true separately for ulcerative colitis and Crohn's disease as well. Also, findings suggest a tendency for periodontitis to be associated with increased risk of ulcerative colitis, but not Crohn's disease. However, more studies are needed to establish a definitive bidirectional association. Our results were published into Frontiers in Medicine Q1 journal. The strength of our meta-analysis was that, to the best of our knowledge, this was the first meta-analysis to investigate the association between IBD and periodontitis from both directions as well. According to the risk of bias assessment, we used high-quality studies, and we followed a rigorous methodology throughout the whole process. And coming to the limitations, as I have mentioned, for our second PECO, we have only found 2 eligible articles. Therefore, we could only see tendencies. Also, we drafted to compare the clinical periodontal outcomes of patients with IBD and IBD-free groups. However, the measurements in the original studies were done not in a standardized way. Therefore, this limited the formal assessment of these values. As an implication for practice, we could conclude that IBD patients should be regarded as a risk population in periodontology. Treating IBD is still primarily a gastroenterological issue. However, we believe that dentists should be part of this multidisciplinary treating IBD patients. Also, dentists should routinely ask if their patient has IBD, because if he has, some precautionary measurements should be done, and the prevention should be even more important in their case than in the healthy population. We believe that patient education is of main priority. Because IBD diagnosis is a lifelong diagnosis, However, compared to this, most patients are usually not aware of their associated risk factors. We believe that they should be also aware of this association, as raising awareness can contribute in patients taking proactive steps in maintaining their health, also which can improve their quality of life. As an implication for research, we emphasize that it should be important to investigate this association between IBD and periodontitis, because we can find some common genetical or immunological pathways, also maybe some common environmental or behavioral risk factors, and identifying them could also contribute in getting to know the yet unknown pathophysiology and the treatment methods for these diseases separately. And coming to our second topic, the title of our second topic was evaluating salivary MMP8 as a biomarker for periodontal diseases. Periodontal diseases are destructive processes involving the periodontium, the supportive apparatus around the tooth. This is made up of the gingival tissue, alveolar bone, cementum, and periodontal ligaments. On the following slides, you can see the parameters of patients with healthy periodontium. Compared to this, in the case of gingivitis, we see bleeding on probing due to the plaque accumulation. However, there is no attachment loss, nor radiological nor clinical. Compared to this, in the case of periodontitis, we experience both radiological and clinical attachment loss. In the histological sample of a healthy gingiva, we see no inflammatory cell infiltrates, there are only a few PMN cells. But only after only 4 days of traumatic effect, for example, not brushing tooth properly, the PMN leukocytes appear and the collagenesis happens. Although this has some histological signs, the clinical signs of the disease come only in a later phase. But there is an enzyme called the matrix metalloproteinase 8 enzyme, which elevates even before the clinical signs. MMP8 is a collagenolytic enzyme. It causes periodontal degeneration. In active periodontal diseases, we see the pathological elevation and activation of MMP8, which is reflected in oral fluids. These are like the gingival clavicular fluid, but it can easily be measured from the saliva. Therefore, the aim of our analysis was to determine whether significant differences exist in the salivary MMP8 levels among individuals with periodontitis, gingivitis, and healthy periodontium. Also, we compared the reliability of MMP8 level measurement with conventional clinical and radiological diagnosis. Our study question was how much higher are MMP8 levels in periodontitis and gingivitis cases compared to healthy patients. Therefore, we formed a PICO framework, and also a PFO framework was formed to compare the clinical periodontal outcomes with the assessment of MMP8. On the following slide, you can see our detailed search key, which resulted in 5,000 articles, and in the end of the systematic search, we ended up with 20 eligible articles. Based on the results of these 20 eligible articles, we compared the salivary MMP8 levels of patients with periodontitis and healthy periodontium in the first case. We found 3 kind of laboratory methods, the ELISA, the IFMA, and the Luminex methods. These methods were evaluated separately and pooled. The mean difference between them represents a statistically significant difference between the groups, which means that patients with periodontitis have a higher salivary MMP8 levels compared to patients with healthy periodontium. In our second analysis, we compared the salivary MMP8 level of patients with gingivitis compared to patients with healthy periodontium. The difference was still statistically significant. However, the difference was not as high as in the first case. In the end, we compared the 2 disease forms, periodontitis to gingivitis. We see that there is still a statistically significant difference between the 2 disease forms. Therefore, we could conclude that patients with periodontitis or gingivitis exhibited significantly higher salivary MMP8 levels compared to those with a healthy periodontium. Additionally, there was a significant difference between the two disease forms, with periodontitis groups showing higher MMP8 levels than gingivitis patients. Consequently, we believe measuring salivary MMP8 levels may serve as a reliable method for distinguishing between periodontal health and periodontal disease, as well as for differentiating between gingivitis and periodontitis. Our results were published in Helion Q1 journal. The strengths of our meta-analysis that this was the first meta-analysis to investigate the level of salivary MMP8 in patients both in periodontitis and gingivitis as well. We evaluated different laboratory methods separately, which is very important because ELISA measures the total MMP8 levels. However, the IFMA measures only the activated forms of MMP8, and pooling them together would cause a significant bias. According to the risk of bias assessment, we used high-quality studies, and here again, a rigorous methodology was followed, which included the PROSPER registration, and we followed the recommendations of the Cochrane Handbook. The limitations of our analysis, that the heterogeneity was quite high in the analysis, we thought that the main reason could be the different populations used in the original studies. Also, we planned to investigate also the chair-side tests, which are available for salivary MMP8 measurements. However, there was only limited data for this evaluation, therefore no statistical analysis could be done. Also, future diagnostic meta-analyses are necessary to define exact cutoff values before implementing salivary MMP8 into clinical practice. As an implication for practice, we believe that MMP8 measurement, salivary MMP8 measurement, can eliminate the limitations of conventional periodontal diagnostic methods, which is like being time-consuming, inconvenient for the patients. However, the most beneficial has the chair-side methods, although there are more studies needed to evaluate the reliability of the chair-side methods. Also, many studies concluded that MMP8 levels elevate even before the clinical signs of the disease. Therefore, it can be a keystone component in periodontitis prevention. Therefore, we can prevent the irreversible damage caused by periodontitis. Among my additional activities, I would like to highlight that both of my studies were brought to Semmelweis Symposium as poster abstracts. Also, I contributed to other clinical studies besides my topics which I presented, and I find it very important to keep myself updated in periodontology, therefore I attend conferences regularly. And I would like to thank you for your attention with the following quote: "Every mountaintop is within reach if you just keep climbing."
Thank you for your nice presentations. I'm turning to the opponent. Do you have any questions? Okay.
Thank you very much for your excellent presentation, really two excellent studies. And I have some questions to both of them. So in first meta-analysis, you showed that patients with IBD have more periodontitis with quite nice risk ratio, so it was higher than 2. But what is your opinion? Did they get periodontitis after or before IBD?
Thank you for the question. It is a very important aspect. These studies, some of them were just case control studies and did not provide information that which was before, but there were
I know, but what is your opinion? Was it before or not, or afterwards?
I think it depends on when they get the IBD diagnosis in age. For example, if somebody gets IBD diagnosis in an older age, then it is more possible to get the periodontitis diagnosis before. But I believe there are also longitudinal studies where patients with the IBD diagnosis was the first, then they got the periodontitis. And there are more studies proving this association. Therefore, I believe the IBD diagnosis is the first, then comes the periodontitis.
Okay, and opposite direction, so people with periodontitis, they don't show some higher risk of IBD, but were all patients checked for IBD or not?
Sorry?
Were all periodontitis, so what's the design of this study? Because some patients come with periodontitis to clinic, and were they checked for IBD, or what is self-reporting or something else?
These were two studies which gave information for the opposite direction. They both concluded that they only included patients which had periodontitis diagnosis but no IBD diagnosis at the 0 point. Then they were approximately 3 years follow-up studies, and they got IBD diagnosis after that.
Okay, thank you. And for the second study, it's also quite interesting study about biomarkers, and you mentioned that you would like to identify some biomarkers for bone destruction, for soft tissue destruction, and MMP is actually some kind of metalloproteinases which is responsible for soft tissue destruction. And my question is, how do you think can this metalloproteinase really be marker for bone destruction, and why?
There are also studies which investigated different biomarkers as well, and all of them concluded that none of the single biomarker could be very, very reliable. The best is to choose 2 or 3 biomarkers together. So I would choose maybe MMP8 and another biomarker which is more specific for bone loss, and investigate them together.
Thank you for your nice presentation. Methodological question. What could be, maybe you know, maybe you don't know, what could be the interpretation of the strength of the odds ratio that you get? So in some cases you got around 2 and the other something about 3. How can we interpret the strength of the association that you found?
The higher the odds ratio, the more the association is between the...
I know that, but related to the number, is the odds ratio to high, moderate, mild?
I think it depends on the case. In this case, I would say it's moderate, because all studies concluded that there is an association, however, it's not very, very high.
Yeah, and 3.5?
I would say it's a bit bigger, but maybe the upper side of moderate.
Yeah. So 2 is mild, and 3 is moderate. So if you have it more than 5, then you say the strength of association is really big. But if it is 2, you know, it's more related to 1, nearer to 1, and 1 means there is no association. Yes. It's similar in both groups. And the other question related also to limitations or the selection bias. I think that I read in your thesis that some of the problems were that the effect of medications and smoking were not controlled for.
Yes.
Was there a possibility in conducting a meta-analysis to control that effect or not? What do you think?
In our original draft, we planned to make subgroups based on smoking habit. However, there were also studies which did not provide information that who was smoking or non-smoking, just a number that some of them were smoking and non-smoking. Therefore, it was not possible to do a meta-analysis based on subgroups based on smoking. Mm-hmm. Also, this is true for the medications. Mm-hmm. Almost all patients with IBD take some kind of medication, therefore we cannot exclude these patients.
There is possibility, so you can contact the persons who published the article and ask them for the raw data. And also nowadays it is considered very polite to have databases available, anonymized, but available for meta-analysis to be conducted. Thank you.
Anybody else? Yeah? Somebody there?
Congratulations on your presentation. Your results are extraordinary. My question is, if there's, let's say, a patient with IBD who regularly sees their doctor and the disease is not flared up, well taken care of. Can you be more specific? What kind of precautions can that patient use to avoid periodontitis? And you also mentioned regular dental checkups. Like how often should that be? And how often should the clinician mention that or refer the patient to the dentist?
Thank you for the question. First, I think it is important that this is also some kind of true for healthy patients and the patients not with IBD, that in every 6 months a patient should go to a dental checkup. But I think in the case of IBD patients, it is very, very important that the dentist should also do a periodontal checkup. Maybe it's not always done in a 6 months visit, but I think it should be very important that these patients should definitely get this periodontal checkup as well. And if we see any kind of mild form of periodontal disease, then this 6 months is not enough. So if we start a periodontal treatment, then there are very close follow-up times, 6 weeks, then 3 months. But I think IBD patients should never be left alone for more than a half year ever.
Thank you very much.
Thank you for your presentation. It's nice. What do you think about a better control of IBD will influence the evolution of periodontitis?
Thank you for the question. I believe patients overall with periodontitis, then only treating the IBD patients wouldn't have so much effect on all periodontitis patients. However, IBD periodontitis patients could benefit if we control them very much. So I think because there are not so many IBD patients as there are many, many periodontitis patients. So if we only treat them, it might not have a huge effect on the whole periodontitis group. However, it is very important to prevent this IBD-related periodontitis.
Thank you so much. And in relation to that, you gave me some inspiration, of course. You know, sometimes also with Crohn's disease, they use the immune therapy as one of the possible options. So coming to his question then, do you think if Crohn's disease is treated with some effective immune therapy, that the periodontitis can be benefited from that?
Thank you for the question. Actually, there are articles which concluded that patients with, for example, TNF-alpha inhibitor therapies or steroid therapies have a protective effect against periodontitis. So yes, there is a possibility that IBD-related medication, mostly for Crohn's disease, can have beneficial effect on periodontitis.
Thank you. And some exciting statistical questions will come.
Thank you. So I have two questions. The first is actually a follow-up question of what the professor asked about the medication type. So in your thesis, you wrote that, so it's related to first meta-analysis. You wrote that the studies had or provided some information on the medication type, and you decided not to do subgroup analysis. So my question is why you decided not to conduct a subgroup analysis based on that information?
Thank you for the question. Because the IBD-related medication is so many times, almost all patients have different kinds of therapies. So one of the problem is that many patients get combination therapy. So it is not possible to put them into, for example, one group because they can get 2 or 3 therapies together. And also there are very, very different kinds of therapies. Therefore, if you put them into subgroups, maybe 1 or 2 patients would go into one group. So it was not possible to put them into groups based on this.
I see. Thank you very much. Could you please go back to the slide when you show us the forest plots of the second meta? Yeah.
This one?
Or maybe the next one. Yeah. So for example, here it's kind of apparent that for the second analysis, the prediction interval is much wider than for the first one. So could you please shed some light on why is that? Why so visible differences can be seen, and what practical or clinical implications so wide prediction interval might have?
I would also like to highlight that here the confidence interval is also quite high. Therefore, the second analysis does not represent statistically significant results. The prediction interval tells us that if we conduct later a study in this area, then this might fall into this range. There are only very few studies, therefore we cannot be very certain where will this study go. So the reliability of this analysis is not so secure as yet. So that's
Thank
why.
you very much.
Anybody else? Yeah. So I haven't asked any from you, just only a small question, because there is one disease which is joining to the salivary glands, you know, and joining for the IBD disease, the Sjögren's syndrome. You know, how impact the Sjögren's syndrome, the MMP8, or have you found any publications, any informations in the scientific backgrounds in terms of the Sjögren's syndromes?
Thank you for the questions. I read many articles regarding MMP8. The major origin of the MMP8 is the GCF, not the salivary glands. Only a tiny amount of the MMP8 comes from the salivary glands. Also, there were many diseases which were associated with MMP8 level elevation, like cancer types. However, these articles did not give any information regarding Sjögren's syndrome, but I think the reason might be because the origin of the MMP8 is mainly from GCF in periodontitis patients.
Thank you so much. And now the public discussion is over, and we have to keep the same protocols. You know, the committee is leaving now, and we need 5-10 minutes for the final assessment. Thank you so much. Ladies and gentlemen, you know, this is the best moment of the day for myself to declare the results. And if the result is so high, then in case of Zsuzsanna, let me share the final results. 23 points from the 25. It means that your qualifications of your degree will be summa cum laude. And last but not least, on the behalf of the committee, we are wishing again a very joyful and a fruitful career for yourself, for the futures, and in your private life. And we are wishing more numerous high-quality publications as well, and keep your scientific group and team together for the future career. Thank you for your presentations, for your work again. And on the behalf of the committee, we are closing the ceremony, public ceremony. Congrats again. Thank you for your attention, for the audience as well.